Hello and thank you for watching. My name is Santosh Sanagapalli and I'm a gastroenterologist at St Vincent's Hospital in Sydney, where I lead the Centre for Swallowing and Oesophageal Disorders, and I look after a large cohort of patients with eosinophilic esophagitis, or EoE. In today's talk, I want to explain one particular part of EoE that sometimes causes worry and confusion amongst patients. That's scarring or fibrosis of the esophagus, as well as the treatment we use to address it, which is called dilatation. My aim is to keep this simple to understand, so if it affects you or someone in your family, you understand what's happening and what we can do about it. So I'll cover three simple questions today. First, what exactly is fibrosis and why does it happen? Second, how do we know if it's there? In other words, how do we find it? And thirdly, and finally, what can we do about it? And this is where dilatation comes in. So firstly, a quick recap of what eosinophilic esophagitis is. Eosinophilic esophagitis is a chronic allergic condition of the esophagus, which is the food pipe that carries food from your mouth down to the stomach. So if we think about this word eosinophilic esophagitis, the middle bit of it is referring to esophagus, which is the food pipe that runs down your chest and takes your swallowed food and fluid to the stomach. The suffix itis refers to inflammation, so we're talking about something causing inflammation of the esophagus. And eosinophilic refers to a specific type of allergic type of white blood cell accumulation. These blood cells are called eosinophils, and you can see they have this characteristic reddish pink appearance when viewed under a microscope. So the central idea I'd like you to take from this talk is that symptoms in patients with eosinophilic esophagitis can occur from two different problems, not just one. The first is inflammation, which can occur, and you can think of this as the active irritation in the lining of the esophagus. The second component which causes symptoms is fibrosis, and fibrosis simply means scarring. Over time, the scarring can build up in the wall of the esophagus and lead to one or more narrowed segments in the esophagus. And the distinction between these two components, inflammation and fibrosis, is important because these two problems behave differently and are treated quite differently. And we'll talk about that more, but inflammation can settle with medication or diet, whereas scarring is more structural change that needs to be treated in a more mechanical fashion. So the next question obviously arises is, why has this fibrosis developed? In short, scarring is simply the result of inflammation which is left unchecked or untreated over time. So this diagram explains the current sort of paradigm or way we currently understand this disease. So initially, we go from a normal appearing esophagus to the start of EoE when there is predominantly just inflammation present. And inflammation on its own can start leading to symptoms, but I think in many people we see more symptoms start to develop as the second component develops, which is fibrosis. And when the lining of the esophagus becomes inflamed, often for years, the wall gradually responds by laying down scar tissue, becoming stiffer, and we get narrowed segments in this food pipe or esophagus. So it's similar to how if your skin was chronically irritated or inflamed, it might develop a scar over time. It's the same thing that happens in the esophagus. The important thing to note is that this progression is not inevitable and is quite variable from patient to patient. So not all patients will end up with a severe scarred esophagus. Some might stay in more of an inflammatory type for quite a long time. But in general, we know that the longer the duration of untreated EoE, the more likely it is that this fibrosis or scarring develops. Because of this, we tend to see fibrosis or scarring more in adults than in children, simply because they've typically had the condition for longer. And as I said, importantly, not everyone will progress to fibrosis, but it's a good, useful way of understanding how this develops. So when fibrosis develops, what actually happens? Well, essentially, the food pipe gets tighter. So the wall of the esophagus becomes thickened, and so that hole, or the what we call in medical terms the lumen, where the actual food goes through within the pipe, there's less space within there. So you can think about like a hose that's been pinched, or a section of a tube that's narrowed down, so there's less room for the food to pass. So these narrowings in medical terms are called strictures, and these lead to obstructive symptoms. And the typical symptom that occurs when this happens is in medical terms called dysphagia, and that just means the sensation of food sticking, or slowness or difficulty of food passing down the esophagus. So people can describe and perceive this differently. Some will feel food sticking, some will feel that it's painful for the food to go down because it's going through a narrowed segment. Some will just feel like they have to chew more carefully and sip water to help facilitate the food going down because of the resistance from the narrow wall. And some patients will have what we call food bolus impactions, when a piece of food is completely stuck and no matter what they do, the patient can't get it down. Sometimes they end up regurgitating the piece of food up, or sometimes they have to even come to hospital as an emergency to have the food taken out for them. And as I said, because this process is very gradual and occurs slowly over time, it's very common that patients with EoE will slowly make subtle adaptations. So they might slowly start chewing more carefully, cutting their food more finely, and eating slowly, and form the habit of sipping a lot of water during meals. And these are often subtle early signs of patients adapting to having a narrow caliber or narrow diameter esophagus. So there's different means of diagnosing fibrosis. The primary means is by endoscopy, and when we do an endoscopy we might see a narrow segment, sometimes so narrow that we can't even get the endoscope through. Barium swallow, I don't think is a test that's required routinely, but in some places they might do this as a complementary test, particularly if patients if there's a strong suspicion that a patient has a stricture but it's not seen on endoscopy. And sometimes barium swallow might pick up a stricture that's otherwise missed. But it's important to note that there's no test that can accurately identify all strictures. And in our own center, we've been interested in doing a lot of research which has shown that all of these tests are suboptimal in diagnosing strictures. So it's important as doctors that we have a high index of suspicion of strictures, and sometimes just perform the treatment from a stricture if we think a patient might have one, even if the tests so far are inconclusive. So this is a broad brush of how I approach the treatment of patients with EoE. And as I mentioned earlier, there are two goals because there are two main contributors to patient symptoms. So firstly, there is the inflammation, as I discussed earlier, and certainly this inflammation on its own can lead to symptoms in patients with eosinophilic esophagitis. And presently in Australia, we have three main groups of treatment options for controlling the inflammation, which are listed here, and I won't discuss any further about these in today's talk. But the scarring or fibrosis component, also called a stricture, this is quite different. As we said, this arises from the inflammation, but there's anti-inflammatory therapies in the dark blue here typically don't have much of an effect on an established stricture. So we have to treat this by esophageal dilatation. So what is dilatation? So dilatation is simply, you can think of it about as widening of the narrowed segments of the esophagus. We perform this during a standard endoscopy procedure that most patients with EoE would be familiar with having. So as a patient, you will be sedated for this procedure. In Australia, we always perform these under sedation. So there are different ways of doing it. Personally, I favor the use of the left-hand side of dilator, which are called bougie dilators, which are long cylindrical tubes with a tapered floppy tip. Um, and on the other hand, some endoscopists use a balloon, like in the right side image here. Um, there are certain advantages or disadvantages to both, but they both can be used. And basically, either technique is used to widen any fixed narrowed segments, which we call strictures. It can be done as a day procedure. It's not an operation in the sense that you don't have any cuts on the outside of the body, and you can go home on the same day after having this. So a basic thing of what to expect. The day before will basically be a normal day for you. Really not much different preparation from having a normal endoscopy. Most doctors who perform this would get you to stop any blood thinning medications just prior, but otherwise most medications can be continued. As explained already, it's done during a sedated endoscopy, so you won't feel or remember anything about having this. The procedure itself should be done within half an hour, and you would expect to go home for the same day. In general, there are a number of patients who won't feel any pain or soreness whatsoever after this procedure is done, but it's not uncommon for there to be some pain or soreness either in the chest or throat following the procedure, which typically won't last more than a few days. I tell my patients that at most you would expect to have to take some paracetamol, but very rarely stronger painkillers might be required. And there's no strict dietary restriction after having this done, but I generally advise my patients to have soft foods purely for their own comfort if they're having pain afterwards, just because firmer texture foods might be more sore. So the big question that a lot of patients have is this procedure actually safe? And the general answer I give is yes, it is safe. As long as the endoscopist is using a careful technique, performing it gradually, and they're experienced with having this procedure, performing this procedure. As I said, chest discomfort or pain is expected, and we wouldn't classify this as a complication of the procedure, and I simply warn all my patients about potential soreness and prepare for that eventuality. And when done by an experienced endoscopist, serious complications should be rare. Back in the early days of EoE, decades ago, there was more fear that this was a risky procedure, but with more experience of how to do this properly, we know we can do this in a very safe manner. And certainly, having one dilatation doesn't seem to have any adverse consequences in terms of having it done again. And I certainly do have patients where I have to repeat this periodically, sometimes once every few years, and it's safe to do so, and that doesn't seem to have any adverse consequence. So again, just to emphasize the point that if performed by an experienced specialist who understands the treatment of EoE, dilatation should be considered a safe, low-risk procedure that can be very, very effective in relieving the symptoms of EoE. So basically, to sum up everything, the main points I'd like you to take home from today is that eosinophilic esophagitis can cause symptoms in patients both from inflammation and scarring. The risk of scarring in any individual patient does increase over time, particularly the time where there has been untreated disease, but is not inevitable. Scarring tends to lead to narrowing of the esophagus, and these are called strictures. And these strictures, I believe, are a major cause of symptoms in EoE. And dilatation is a safe, highly effective way to restore normal swallowing capability when strictures have developed. And thank you so much for listening, and I hope you found that talk useful.